We quickly realized that this was next to impossible for our patients because we are in a urban city. We have lots of multi-generational households, lots of small households, lots of shared rooms. So as the epidemic in our area increased, if I'm being honest, we were having a hard time trying to stick with this policy. But in the perfect world, that would be a criteria for discharge.
So you had to admit them to the hospital instead?
Our city developed areas where people from group homes or convalescent settings or homeless people without the ability to self-isolate at home. Chicago opened up hotels for those patients. There was also large gathering and other shelter type accommodations.
And so the same has happened in the Pacific region. So most of you most of the Northern Pacific island countries do have an isolation or quarantine, an isolation unit for people that actually have COVID-19, but don't necessarily need hospitalization. Most of them have worked that out. And the difficulty is you have to have wraparound services, which means trash and food and toilet paper and everything else that you need to get through your illness. One last question I have for you, Dr. Martin, is did you use blood gases to make this decision at all?
No.
Just oxygen saturation.
Correct. Yeah, we found that was just fine to evaluate these patients, unless they are critically ill. We did not get a blood gas on most patients.
I saw you had criteria for saturation around 94%. Was there also criteria for respiratory rate?
There was not. No, not when you're dividing the disease by mild, moderate, or severe.
So you're just looking at the work of breathing, sort of. Correct. Overall.
Yes.
Okay. Thank you.
Sure. This is just a list of the other corresponding health issues that would make the patients at risk for either death or admission to the ICU. We know that increasing age has worse outcomes. The fatality is highest in persons above the age of 85. That range from 10 to 27%, versus the next age group lower, 65 to 85, which had a mortality of 3 to 11%. And when you get less than 64, the group 55 to 64 had a fatality rate of about 1 to 3%. Also, the greater number of comorbid conditions increases the risk of death as well. Hypertension increased that risk by 2.4 times. Any diseases of the lungs, such as COPD, increased the risk of death by 2.4. Cardiovascular disease increased it the most by 3.4, and diabetes, while not statistically important, increased the risk of death by 2. In addition, if you are a current smoker or are obese, that increases your risk of admission to the ICU. And if you are obese, that more than double the risk of ICU admission once you are hospitalized.
Dr. Martin, do you know if it does, at one point, gender had played a role here too, and it felt like men were more likely to have a severe disease?
Yeah, that's true, and that hasn't really been hashed out as to why. It's difficult to separate the fact that men are more likely to get infected. Therefore, there are more men in the hospital compared to women. But you're absolutely right. That is a risk factor both for more severe disease as well as getting the infection just in general.
They may be more likely to have one of the comorbid, significant comorbid conditions as well. Over.
Correct. Mm-hmm. This is from a paper that I'll describe in more detail, but they talked about the severity-dependent protocol to manage COVID. And I tried to put this in more of a flow diagram just to make it easier. It progresses from phenotype 1, which is that mild disease, all the way to phenotype 5, which is the development of ARDS. And the idea here is that you have to provide increasing oxygen therapies as you progress through the phenotypes. So at phenotype 1, which is mild disease, they have fever, mild respiratory symptoms. They might have a cough, mild shortness of breath, but they are able to maintain their oxygen saturation without any supplemental oxygen, and they don't have any changes on their chest x-ray. These patients could be safely self-isolated at home, and you only treat them just based off of their symptoms. Phenotype 2 is moderate disease, and these patients have an oxygen saturation less than 93%, or they have chest x-ray opacities. These patients have to be washed in the hospital, and the treatment is both supportive and through oxygen through a nasal cannula. And you know if the nasal cannula is working if it's effective at keeping the oxygen saturation above 93%. If the disease progresses to phenotype 3, that's known as the precritical stage. This is when they have severe hypoxia with an oxygen saturation less than 88%, but they respond to high flow nasal cannula or face mask. And these patients are really at risk for decompensating. So they should be washed in a sub-intensive care unit if available. The treatment is to provide oxygenation through high flow nasal cannula or face mask. And again, the goal is to keep it above 93%. This is also where you should start to use prone positioning. And I'll briefly touch on that, but I'm hoping that the next lecture will also talk about that as well.
Dr. Martin?
Yes.
Were you concerned with high flow oxygen of aerosolizing COVID for the medical staff and the nurses?
Yes, and I do have information on that as well. The more intense oxygen that you are given a patient, the more likely it is to aerosolize the virus, and the more at risk healthcare workers would be. But I do have a chart that also describes that. Phenotype 4 is when patients have a high probability of developing ARDS, and these patients should be admitted to an ICU because they require non-invasive positive pressure ventilation either through a BiPAP or a CPAP. Again, the target is to keep it above 93. These patients can also be prone as well. And if the target is not reached after 2 hours, you progress to phenotype 5, which is when the patient actually has ARDS and requires endotracheal intubation, and they would need invasive mechanical ventilation as well. The idea is to keep high PEEP values and frequent repeated positioning with prone ventilation if possible. So again, this is the flow diagram, and you progress to each stage if your target oxygen saturation above 93% is not reached. As was previously mentioned, the different ways to give patients oxygen have different what we call dispersion distance. So dispersion distance describes how far droplets will travel in a closed room. And you can see that just with a nasal cannula, the dispersion distance is quite low. But as you increase to a simple max to non-invasive positive pressure ventilation, that increases the distance that these droplets will travel. So the greater the dispersion distance, the greater the risk of aerosolization, and the higher the risk of aerosols, the greater the need that the staff wears a respirator. And it also follows that these patients should be isolated in their own room if available. Just wanted to briefly touch on prone positioning. We started to get hints that this was a good idea early in the epidemic. And anecdotally, I have seen pretty good results in someone in that phenotype 3 stage, if I am able to prone them. But this was actually a study that proved it. So they looked at 56 patients who were placed into a prone position for 3 hours on day 1 of enrollment. And they have the option to continue periods of proning the rest of the time in the hospital, or if the treating physician advised them to do. They said that proning was feasible in 47 patients, meaning that 84% of patients were able to tolerate 3 hours on their chest. What they found was that prone positioning rapidly increased oxygenation, and that improved oxygenation was maintained in about half the patients after they then flipped over onto their backs. What about co-administration of antibiotics? I can tell you that bacterial and fungal co-infection, if someone has COVID at presentation, is quite rare. There are a range of studies that describe this. However, this was the best, most inclusive study that I could find. This was a review of 1,007 abstracts and 18 texts. About half of those described COVID-19. About 30% described SARS-CoV-1 and 6% MERS, and then there was a few other non-pandemic coronaviruses. For COVID-19, though, only 8% of patients were reported as experiencing bacterial or fungal co-infection during their hospital admission. That includes time from admission to discharge, despite the fact that 72% of patients received broad-spectrum antibiotics. We have seen co-infection with other viruses because the pandemic kind of started at the tail end of influenza season. We did see co-infection with influenza A and B. And then later on, they would have co-infection with RSV or other coronaviruses or endovirus or something like that. But I have yet to see someone who presented to the hospital with a coexisting bacterial infection. And at our institution, we do not prescribe antibiotics in a person with confirmed or highly suspected COVID-19. That being said, there have been a number of cases of ventilator-associated pneumonia, but this typically occurs a week to 10 days after they have been intubated and not on presentation.
Dr. Martin, this is an important point. And when we were first planning to help prepare the jurisdictions, and based on the prior flu outbreaks and epidemics, it was recommended that lots of antibiotics be administered at basically the drop of a hat for anyone who had pulmonary symptoms, even if we were pretty sure it was COVID.
Right.
But then interestingly, it's pretty clear that that's not required. And so we've actually pulled back from trying to push hard on procuring ceftriaxone and azithromycin and other commonly used drugs in the Pacific on the wards and in the ICUs. So your experience seems to support the fact that we're not necessarily going to routinely provide a secondary treatment for a secondary pneumonia that hasn't been diagnosed.
Yeah, I mean, I truly feel that that's not going to benefit the patient and only introduce a toxicity that could be avoided. Then now I just wanted to briefly touch on some of the drugs that have data. And the first drug that everyone always asks for is hydroxychloroquine. Everyone here knows is that this was kind of fraught with controversy. The reason it kind of came to everyone's attention was that hydroxychloroquine and chloroquine have been shown to inhibit viral loads in vitro. So when we grew the virus in petri dishes and then added the drug, there was more viral control in those petri dishes. This was followed up by several very small studies that showed more rapid viral clearance, which was defined as time to negative PCR, in patients treated with hydroxychloroquine with or without azithromycin, compared to supportive care alone. But they did not include any clinical data in these very small case studies. They didn't include time to discharge from the hospital. They didn't include admission to the ICU. So we don't have any clinical data on these patients. Nonetheless, because of lack of options, the FDA approved hydroxychloroquine under emergency use authorization on the 28th of March. And then all these larger studies started to come out. And most of the studies showed increased risk of death due to arrhythmias without any benefit to the patient. There was a large study in Brazil that used not hydroxychloroquine, but it used chloroquine. That was discontinued early because there was an increased rate of death in the treatment group. There was a study in the recovery trial out of Oxford, England, that also didn't show any benefit, but some increased harm. And there was a large study out of the VA hospitals in the US that also didn't show any benefit. And that all kind of culminated in this retrospective Lancet study that was quite large, of 9,600 patients. The paper has since been taken out of the journal, that were treated in multiple countries that did not show a benefit, but a higher risk of death in the treatment group. So everyone kind of flipped their course, and the World Health Organization then discontinued their own hydroxychloroquine trial, and the FDA discontinued the EUA on the 15th of June. So hydroxychloroquine has really fallen out of favor. There's no evidence of benefit, and there's a potential for increased harm. You'd be hard pressed to find an ID doctor that would prescribe it to any of their patients. I do not give it to any of my patients in the absence of a trial setting. However, there remains no randomized, double-blind, good placebo-controlled trial for this drug. At our institution, we are currently enrolling for trials for ambulatory patients in a randomized fashion. However, because of all the controversy, we're actually having a harder time trying to enroll patients. So I don't know what's going to happen with that study.
Dr.
Yes.
Hello. Yes, this is Dr. Chen from Family Health Air Force Base in Guam.
Hi.
Recently I read some paper regarding, I think it's from the journal Infectious Disease. It's published by the Michigan Wednesday. I don't know if you read that paper, but it looks like it still has this medication still in the game, but they just need more further evaluation. I don't know if you have any.
You're talking about hydroxychloroquine?
Yeah, that's correct.
Yeah, no, you're absolutely right. I mean, I don't think all the data that we have, the preponderance of data shows that there is no clear benefit, and there is likely increased harm to these patients. But I mean, again,
they say the study mainly is a study for the severe patient, critical patients. They didn't do the early mild moderate patient for with this medication. So yeah, that's all controversial at this time. I'm not pushing for it. I'm just saying that the patient, the medication is still in the game.
Sure. Yeah. Thank you.
Thank you.
Yeah. So let's move on to the only known antiviral to have activity against SARS-CoV-2. This was a double-blind, randomized, placebo-controlled trial where half the patients got the antiviral and half the patients did not. This was over 60 trial sites, most of which were in the United States. All the patients received the standard of care, and the primary endpoint was time to improvement of symptoms. The inclusion criteria was quite simple. It was anyone with COVID-19 and the need for supplemental oxygen or chest X-ray evidence of pneumonia. And the exclusion criteria was AST or ALT above 5 times the upper limit of normal, or creatinine clearance less than 50. What they found was that the RDV group had shorter time to recovery than the placebo group, with a difference of 11 versus 15 days. And this was off of 1,000 patients that were analyzed. They did show a mortality benefit at day 15 that was lower in the treatment group, but it did not reach statistical significance. This was the recovery by a subgroup analysis. This is the forest plot. And I won't have this up for too long, but suffice it to say that There weren't a lot of values in this study except for symptom duration that was found to be statistically significant, favoring the treatment group. So the potential conclusions from this paper, and again, this is only a prelim report at this time, was that it does not appear to provide any more harm than placebo. The risk of adverse events in both groups were about the same. It does have a positive effect with respect to time to symptom recovery in those requiring oxygen, but they found, if in the subgroup analysis, they found less of an effect on those with more severe disease, specifically those requiring invasive mechanical ventilation or ECMO. And so this is directly from the paper. The preliminary findings support the use of this product for patients who are hospitalized with COVID-19 and require supplemental oxygen therapy. However, given the high mortality despite the use of remdesivir, it is clear that treatment with an antiviral drug alone is not likely to be sufficient. Future strategies should evaluate antiviral agents in combination with other therapeutic approaches to improve patient outcomes in COVID-19. So this is not the magic bullet that everyone has hoped it would be. It is something. There is something here. We'll have to wait for the long-term data set to come out. The next data set that will come out is the 30-day follow-up instead of the 15-day follow-up. And it's possible that there might be the mortality benefit might be in that data set where it was not achieved in the initial studies. Just briefly, I just want to talk about colchicine, just because this was an interesting recent paper that I thought everyone should be aware of. And the idea behind using these immunomodulators is thought that the ARDS is driven by this intense inflammatory response. And so that's why they thought that they could use colchicine. This was a prospective open label randomized trial comparing optimal medical treatment to colchicine across 16 hospitals in Greece. And it's important to know that patients in both groups did receive hydroxychloroquine and or azithromycin. It was in the high 80s in both groups did receive those drugs. But they ended up with 50 patients in the control group versus 55 in the treatment group. They used a loading dose of 1.5 followed by 0.5 milligrams 60 minutes later. And the endpoint was time to clinical deterioration and elevation of inflammatory markers. We found that the primary endpoint occurred in 7 patients in the control group compared with 1 patient in the colchicine group. There wasn't any difference in elevation of inflammatory markers, including troponin and CRP in both groups. And there was no evidence of major adverse reactions in both groups, except the group that got colchicine had a lot more diarrhea than the group that didn't. By the author's own admission, the study was greatly underpowered. They were hoping for about 180 patients to be enrolled in each group. And they said that this was because the incidence of COVID-19 in Greece towards the end of the enrollment period fell greatly, and they weren't able to finish the study. So now let's move on to dexamethasone. Again, it's the idea behind it is that it could potentially improve the inflammatory state. This was part of the recovery trial out of Oxford, England, which is this big consortium of trials. It's a adaptive trial. So once they find a good idea, they're able to recruit more patients to that arm of the study. They compared 2,104 patients that were randomized to receive dexamethasone at a dose of 6 milligrams once per day. They did allow for oral or IV for 10 days, compared to 4,300 patients who received standard of care. Dexamethasone reduced deaths by 1/3 in the ventilated patients and by 1/5 in patients receiving oxygen only. There was no benefit among those who did not require any oxygen support. And the number needed to treat was 1 death prevented for every 8 ventilated patients treated with dexamethasone compared to 1 death prevented for every 25 patients on oxygen. So in this trial, it appears that the patients with the worst disease did do better if they did get steroids. And so dexamethasone was really the first drug found to improve mortality in patients with severe COVID-19. It's a drug that's cheap, it's easily accessible worldwide. There's a clear indication for this drug. Those who require oxygen could potentially benefit from it. It's unclear if more steroids will lead to greater improvement. Dexamethasone 6 milligrams a day is really not that high of a dose. I think it's comparative to the dose that you would give someone with an acute gout exacerbation. So it's unclear if you gave more steroids, if that would be better. And it's unclear if you could also compare this drug to other steroids. However, there are these conversion charts online, and I just wanted to make everyone aware that the dose that they use, dexamethasone 6, is equivalent to methylprednisolone 32. You'd have to divide that up because it's a drug with a short half-life. Prednisone 40, hydrocortisone 160, again divided, and cortisone 200 milligrams divided throughout the day. So just to go back on our hospital guidelines, that's the separation between mild and critical disease. This was the EUA for that we used in our hospital. I just want to note that, and I didn't talk about this earlier, the dose that we used was a loading dose of remdesivir 200 milligrams on day 1, followed by 100 milligrams daily thereafter. For 5 days, because there was other papers that were published that 5 days is equivalent to 10 days in most patients. However, in that trial, they did have a lot less patients on with severe disease than they had patients that had a moderate disease. So in conclusion, the initial assessment of a COVID patient includes vital signs and any comorbid conditions that may make the patient at risk for severe complications. Treatment is largely supportive, with increasing oxygen therapies to keep the oxygen saturation above 93%. Prone positioning improves oxygenation and may delay time to intubation. Antibiotics are not necessary. Hydroxychloroquine and colchicine could potentially be helpful, but further trials are needed. At this time, the risk of treatment, at least for hydroxychloroquine, doesn't seem to outweigh the benefits given to the patient. The remdesivir improves time to recovery without any mortality benefit, and that was found more so in patients that required supplemental oxygen that weren't on ventilators. However, dexamethasone is the first widely available drug to have clear benefits, and the patients that with more critical illness had the most benefit. So I just wanted to say thank you, and I'd be happy to take any questions.
Can you back up one slide just so we can see those summary conclusions, which are really great? And a reminder to all our clinicians, the slides are going to be posted and available for everyone to download. Thanks to Dr. Martin. This is a brave talk because we know that things change and that this is rapidly changing situation clinically. You know, a month ago, if you would have done this talk, this last discussion of dexamethasone would have said, do not use steroids, they provide no benefit and might provide harm. Now we know that's not the case. So we're learning as we go. And so I appreciate you giving us the most up-to-date information on these meds. And basically this is why a month from now, we'd like to have another talk just like this one to go over all the medications, because there'll likely be some changes in the recommendations.
Interestingly, and I just wanted to mention in that steroid study with the dexamethasone, they did not find any bacterial super infections in those patients, which was one of the concerns. If you're giving them an immunosuppressant, would they be more at risk for bacterial super infection? And it was not found in that study.
Right. I would see here's a question from Dr. Hufschneider in CNMI. Is there any benefit, do we know, of giving dexamethasone for those who are not intubated?
There is benefit if the patient requires oxygen. If it's a mild disease, there doesn't seem to be a benefit. But if they require oxygen, then there is a benefit. Less of a benefit if you had a critical disease, but there is a little inflection point where there is benefit.
Yeah, I think that was pretty clear and statistically significant that even if you weren't intubated, if you required oxygen, it was worthwhile giving the dexamethasone. There's a request to go back to the steroid equivalency slide. Folks are probably scribbling that one down because dexamethasone is not available in all the jurisdictions. I would say probably most of them have it. And I know that orders were going out for dexamethasone after that study was published.
Sure. And I got this information from just a quick Google search. So the information's available out there if you need it.
So if you had a patient now that couldn't keep their oxygen above 93 without supplemental oxygen, what medications would you put them on, Dr. Martin?
I would definitely give them the antiviral. They would definitely be a candidate for the remdesivir. And then I would see how they do. There's no data combining the two. Obviously, there's no data for an antiviral plus steroids. It seems to be that the initial stage of the disease is characterized by viral infection. So intuitively, and there's a little bit of data that at that point they do better with an antiviral. Later on, when they do develop ARDS, it seems to be all inflammatory mediated. So that's when the steroids would come into play. So you kind of have to see where the patient is on that spectrum.
Great. And Dr. Hofschneider has gotten ahead of me on this one for my next question, which was, how often are these patients changing criteria? You've got those 5 categories, which I haven't seen before, and it looks like it's really a great way to think about this. How often and how quickly are they moving from one phenotype in the other? For example, how often are you going to need to put your nurses or yourself to go on rounds and reassess with saturation and with work of breathing to determine if you need to change up?
Just from personal experience, most patients do just fine on a nasal cannula. The patients that require a face mask, so when you get to that phenotype 3, that is what I would say is the riskiest patient, because you could have a rapid progression in their oxygen needs after you hit the phenotype 3. So I would say if you could identify someone that you have just placed on a face mask, that would be the patient that I would prioritize.
So when you say prioritize, does that mean check on in 8 hours or 2 hours or 30 minutes?
Check on in 30 minutes. Yeah.
And reassess, right? Okay. And in the phenotype 2, how often typically would it be every shift, or how often would you be reassessing them?
Unless I was concerned, I would ask the nurses to check on them more often, but we would do it in vitals Q4. And I think if the patient's been in phenotype 2 and they're doing okay, I think that's adequate.
All right, that's great advice.
Dr. Martin, this is a question again. You turn back to the antiviral treatment, do you have the criteria when to start the oxygen level? Is it like a phenotype 3 to start the antiviral treatment, or it's kind of depend on the how the patient situation?
It we started everyone on it if they were on oxygen. We were fortunate at our institution that we had enough of the product to go around, and so in that case, we also kind of received it kind of at the end of our peak as cases were going down. So we thought we would have problems with the supply, but we ended up not having those problems, which we were lucky. So I would start anybody on it when they are admitted to the hospital and need oxygen.
I think for us in the region, we're not that lucky. We did get surprisingly and successfully, we're able to ship out a small number of vials of remdesivir to each of the 6 U.S. jurisdiction capitals, but it's still a very modest amount. For example, I think FSM, which has nearly 100,000 people living there, I believe they have enough for 5 cases. So it's there for you to use, but unless something changes in the drug supply, I don't think it's something you can count on for every case that meets that criteria, should you have an outbreak.
Yes, agree.
Unfortunately, I think, Dr. Martin, I hope you can hang around while your colleague gives us the next talk, but I'd like to move on to the next talk if we could. Again, you set the bar pretty high here, but I have a feeling that Dr. Shahjabat is going to be up to the challenge. So please take the screen.
Hi, is everyone able to hear me?
Yes, we hear you fine. Please go ahead and click on the slideshow or the presentation view.
All right, fantastic. All right.
Perfect.
All right, thank you, everyone. Thank you, Dr. Brostrom. I am Shashwat Sukal. I'm one of the attending physicians here at Cook County Hospital in the Division of Pulmonary Critical Care. And I will be presenting treatment of severe disease for people with COVID-19. So thank you all for coming. Before COVID hit us in Chicago, I remember a very similar talk that physicians from Italy and Poland had given us in the Department of Intensive Care. And this was all over Skype, and we were all sitting around a table just like this. And they sort of told us their experiences of COVID-19. And, I just remembered that when I saw that little conference room, because that reminded me of the same talk that we had. But just a little bit of background about me, who I am. I trained in India. I went to medical school in the Armed Forces Medical College. You can probably see me, the tall, lanky guy with no hair in the middle. I then went on to do my internship in a civilian hospital. Went to Singapore. I worked in a large multi-specialty hospital in Singapore General, and then came to Stroger Hospital somewhere in 2011, where I did my residency and my fellowship in pulmonary critical care. I've been attending ever since. I spent 2 or 3 years as a medical officer in various smaller hospitals in India before I sort of embarked on my world tour. But now I'm here. And today we're gonna talk about Basically, I've broken my talk down to 7 topics. The first one will be recognition of severe disease and ICU triage. Then we're going to talk about modalities of respiratory support. I'm going to talk a little bit about intubation of patients, just from the practical standpoint of how to set up an intubation, how to set up the room, and PPE concerns, then ventilator management, prone positioning, and then just general critical care for COVID-19. And then I have a few points on the preparation for a COVID surge. If there are any questions, Dr. Brostrom, are we going to stop, or are the questions are at the end? I'm fine with it either way.
I think we'll try to keep the questions in the midst of the talk, if we could break it in as they appear. And if that becomes too interruptive, and I'm probably more guilty than anyone else, but if it does become too interruptive, then we'll just let you plow ahead and we'll finish at the end.
Sure. I would prefer prefer to be interrupted. I think I'd like the interaction. So that would be great. My basic approach to this will be a case-based approach. And so I will use cases to sort of talk about our points. So our first patient story, and these are all real cases, but first patient story is of a 59-year-old man who had a cough and fever for 6 days. He comes to the emergency room for these symptoms. His son and daughter-in-law were sick a week ago. He has no known past medical history, works as a cook, never smoker, no drugs or alcohol. And he is febrile, he's a bit tachycardic. And off the bat, he requires some oxygen in the emergency room. However, the notes document that he looks well, he's able to walk, talk, and eat comfortably. His COVID screen comes back positive, and some of his labs, ferritin was very high, 2,400, CRP of 17, D-dimer of 1.3. We've sort of used these labs as markers of severity of inflammation as a hospital, and we can talk about the utility of these later. But for now, I'll proceed with the case. This to me is the most important part of the picture as a pulmonologist, is the chest X-ray. And I don't know if everyone can see this as well as I do on my screen.
It's projecting well, thank you.
All right, thank you. We see a peripheral infiltrate. Can you see my mouse?
Yes, we can also see the mouse.
We see an interstitial sort of infiltrate here bilaterally. I think this area is soft tissue thickening, but there's no obvious consolidation, no pleural effusions, no cardiomegaly. You can see both the diaphragms outlined very nicely. So no lobar consolidation, just an interstitial sort of pattern that we would say is consistent with COVID-19. So he gets admitted to the hospital because he's hypoxic. He's initially triaged to the general medical floor. He's treated with Tylenol, cough syrup, and oxygen. He's given enoxaparin for DPT prophylaxis. And ID services consulted for remdesivir. He then gets remdesivir, but his oxygen saturation is now a little bit lower, oxygen requirements are higher, but notes document that he does not appear to have increased rate of increased work of breathing. He does continue to have high temperatures and he remains tachycardic. And the next day, CRP, ferritin, and D-dimer double. So this is a repeat X-ray. And as you can see, the infiltrates have clearly progressed. Now you can see some sort of confluence of infiltrates. I still wouldn't call this consolidations, but you see a confluence of the interstitial infiltrates in the peripheries with central sparing. And this is as a pattern pre-COVID, I would say this is a diagnostic of chronic eosinophilic pneumonia. which is what we call a radiographic negative of pulmonary edema. Pulmonary edema is batwing more perihilar and spares the peripheries, and this is the complete opposite. It involves the peripheries and spares the hilum. And this is a feature of interstitial pneumonia, COVID-19, and infiltrates have progressed. So now MICU is consulted. He's on 5 liters, breathing breathing a little bit harder. His respiratory rate is 30 per minute. Oxygen saturation is 88 to 90% on 5 liters. He's not able to speak full sentences. So he's taken to the ICU. High flow oxygen is started, and an ultrasound DVT is ordered. We use high flow oxygen. Interestingly, Dr. Martin presented, the dispersion of high flow oxygen, and this was a considerable debate within our division on, when and how to start this, and and it's actually the dispersion for high flow oxygen is actually lower than some of the other modalities, and we think that may be due to the good seal that the nasal pillows have over the nose to create that high flow. But nevertheless, we started all patients on high flow. We had a HEPA filter in the room. So this is a little mobile, portable filter that gets hooked onto power, and it sort of sucks up all the air in the room and cleans it out. So any high flow and non-invasive treatment modality, we either had a negative pressure room or a HEPA filter in the room. So in terms of specific therapy, he gets the remdesivir, he gets the tocilizumab, he gets convalescent plasma, he gets a full dose anticoagulation for chronic DVT, he gets antibiotics for a secondary UTI, and we find out that he's diabetic, and he starts to get insulin. And this is a success story. He's eventually weaned down to nasal cannula, and he responded pretty well to prone positioning. And he was talking and eating throughout his stay. And then this patient was actually discharged home on anticoagulation and oral antidiabetic therapy after spending 2 weeks in the hospital. So just this is his respiratory rates and his oxygen saturation. And what I wanted to bring, the point I wanted to make, and this is someone said in the chat about the permissive hypoxemia and the happy hypoxic, and this is one of the good examples, I think, of a happy hypoxic. Now, before the COVID era, if I was rounding in the ICU and I was told that someone had a respiratory rate of 48, I don't know if you can see these figures. This is 50 right here. This line is 50. This is a chart of his respiratory rate over time. So this is day 1, day 2, day 3, day 4, day 5, day 6. Look at his respiratory rates. They're in the high 40s. They're even touching 50s. And his corresponding oxygen saturation on high flow is 89, 88, 90, 91, goes as low as 85. So if I was in the ICU pre-COVID and a patient was breathing at 50 per minute and had an oxygen saturation of 88, 85% on high flow oxygen, that patient would be intubated before the presentation was over. But this is just one of many patients that we saw with COVID who actually tolerated this pretty well. And all throughout this, he was eating, drinking, and walking to the bathroom. And it was surprising to see these patients even sleep with a respiratory rate of, high 30s. So definitely not behaving like our usual pneumonias and ARDS. So maybe there is something different here, but this graph actually captures that pretty nicely for him. Never intubated. Our second case, 48-year-old female with a history of diabetes and obesity. Again, very similar story, 1 week of illness, multiple sick family members. She comes in febrile, respiratory rate is 24. She's 88% on room air, 95% on 2 liters. Again, no distress, talking full sentences. COVID labs positive. She has a high ferritin, D-dimer. She has bilateral infiltrates on the X-ray. The ultrasound is negative for DVTs. And similar X-ray in the sense that the infiltrates are peripheral again, interstitial. There's no alveolar filling process. There's no air bronchograms. There's no lobar consolidation. Diaphragms are nicely visible. So, you know, most of the lower lobe is actually not consolidated. There is some perihilar fluffiness in this case, but that may be some mild fluid overload. We don't know. Similar picture for her. You can see that her respiratory rate is also in the high 40s. Oxygenation is lower, 84 to 90. And interestingly, both of these patients actually didn't have a very high heart rate. So you can see if you see the respiratory rate of, when she has a respiratory rate of 45 per minute here, heart rate's 90. Typically when we see patients who have respiratory failure and they're breathing at 45 breaths per minute, their heart is running at 120 or 130 beats per minute. But this was not the case for many of these patients. This patient was treated with CPAP. One, because she was obese. She had a history of sleep apnea. So we decided CPAP would sort of help with oxygenation and keep her upper airway open. She didn't require more than 60% oxygen with the CPAP. And we also treated her with prone positioning as tolerated. Prone positioning practically is a little bit harder with NIV, just because there's more on the patient's face, there's more tubes and a mask. She was treated with tocilizumab and hydroxychloroquine, and she made a full recovery and she was discharged home. So the topics that I wanted to sort of talk about with cases 1 and 2 are these 3, which is recognition of severe disease in ICU triage, the modalities of respiratory support, and awake prone positioning. So for me as an intensivist, recognition of severe disease is purely physiologic and a clinical assessment. Heart rate, respiratory rate, and pulse oximetry are vital. They're vital signs. And the other vital sign for me is the assessment of work of breathing. The assessment of work of breathing is a very subjective assessment, and it varies from person to person. But essentially, I look at the use of accessory muscles like sternomastoids, tracheal tug, nasal LR flaring, pursed lip breathing, and things like that. The other important parameter of severe disease for me is the chest X-ray. If we see severe infiltrates on the chest X-ray, or if the chest X-ray is progressing quickly, i.e. admission chest X-ray was okay, and the chest X-ray a day later is worse, then that's a point of concern. Laboratory markers such as ferritin and D-dimer and CRP are useful if they're present. However, I wouldn't use them solely. Maybe I would not even use them at all. But if they're present, then they do give a good indicator, or I would say they're corroborative data. And the data does show that higher age and more comorbidities are associated with severe disease. But we've all had patients who were very young, who had maybe diabetes, if anything else, and who've had severe disease. So I think at the individual patient assessment, we've seen young people being intubated and young people dying. So I think at the individual level, the risk assessment should not take age into consideration, because we've seen older people who've had very mild disease and we've seen younger people with very severe disease. But statistically overall, it is true that older age and higher comorbidities are obviously predictive of mortality.
Dr. Sukal, you
Yes.
did ultrasound for DVTs on both of these patients.
Yes.
We know that there's a severe hypercoagulability that seems to be present, and that prophylactic prevention with anticoagulants may be standard for some programs. Can you talk about that briefly?
Yes, that is a very good question, Dr. Brostrom. And we have had very heated debates about this in our institution internally, and even within the Division of Critical Care. And I can tell you that there are about 13 attendings in our division, and we have 13 different opinions on this. And I have colleagues who give high dose heparin for everybody. I have colleagues who have not changed their practice at all. And I have people who are in the middle, and I'm sort of in the middle with this. There is data definitely to show that there may be a higher risk of DVTs and VTEs with this. Now, how much of that is because these people are sicker and intubated and immobile for a long time? That remains to be seen. Using D-dimer is, 30 years of critical care has told us that D-dimer is acute phase reactant, and it's elevated in acute illnesses. So it should not be used to diagnose a PE. There are risks and difficulties with diagnosing PEs, taking these patients to CT scanners. Quite often they are very sick. They can't even go for an angiogram. So my practice has been to try and get an ultrasound DVT for almost everyone who's in the ICU. Everybody gets low dose, or actually we're doing intermediate dose heparin for prophylaxis, the same dose we would use for someone with prostate cancer or post-hip surgery. And if there's a strong clinical suspicion, we start full anticoagulation. If I have any other reason to start anticoagulation, such as atrial fibrillation, or if the CRRT or the CVVH machine gets clotted frequently, we'll do heparin drips. And certainly we've seen bleeding. We've seen bleeding complications. We've seen stress ulcer bleeding. We've seen retroperitoneal bleeding. So it's a difficult decision. And I am not one of those who would start anticoagulation on everyone. I would not use the D-dimer solely to start anticoagulation, but I would definitely scan these people maybe every week while they're in the ICU, when they're, especially those who are paralyzed or deeply sedated and have been in the ICU for weeks. And if the chest X-ray is not very profoundly bad and the patient is very hypoxic, in other words, if there's severe hypoxia with a relatively uninvolved lung in terms of infiltrates, I would consider empiric anticoagulation in that case, or maybe a trip to the CT scanner. I think there's a lot of controversy about it, and I'm sure there are other opinions on this. We are still waiting for definitive data to guide us on that, I think. But it's a great question, very contentious. There's some people in New York who are giving TPA. Mount Sinai has protocols for heparin drip. But I think when the dust settles, we'll know, we'll have a better idea. But yeah, that's all I have. My approach is a little intermediate approach. But we're certainly using twice daily enoxaparin.
So this is Dr. Vita from Kasai. Can I ask for easy questions?
Sure.
Yeah. While we're on the subject of anticoagulation,
sure.
I noted that in one of your patients, you were giving him or her both anticoagulant and plasma. Was the plasma as a volume expanders, or is it also to provide some
okay, good question. Thank you. Thank you for bringing that up. So, yes, sorry, do you have another one?
The other one is the fast rate of breathing, like a compensation for not having enough oxygen, so they breathe faster to get as much as they can out of the small oxygen saturation.
Okay.
And the third one is, I'm sorry.
Go ahead.
Go ahead. I'll ask. Okay. The third one is, how much IV fluid do you give in these patients that are not having infiltrates, but they have the interstitial pattern? And the last one is, you were giving cough syrup. What kind? Is it a expectorant or is it an stop coughing kind of?
All right, thank you. So I have 4 questions. I think I'll get your last question first, which is the cough syrup. And to be honest, I have no idea what kind of cough syrup was given to that patient because that was on the floor. But I don't think it matters either ways. We do probably dextromethorphan, but there's no strong rationale for giving it or not giving it. I don't have any strong opinions about it. Your question on IV fluids, I think we generally, IV fluids is only as sort of maintenance fluids, if at all. The ARDS trials have shown, the FACT trials have shown that a dry lung, extravascular lung water as little as possible liberates people from the ventilator earlier. So the IV fluid would only be to maintain adequate urine output as a maintenance fluid. Some of these patients have had shock, a severe cytokine storm and shock. And in those cases, they're given boluses to keep their blood pressure up while pressors can be started. Your question on plasma. So the plasma was actually convalescent plasma. Our hospital is one of a trial site for the use of plasma from donors who have recovered from COVID-19. So in conjunction with the Mayo Clinic, we were doing this, and I'm one of the co-investigators for that site, at our site for that. So it's essentially people who have recovered from coronavirus infections, and they're 21 days out. They donate their blood to one of the few blood banks in Chicago. And then we ask for plasma from those donors. The idea is that they have antibodies which may help the infection, convalescent plasma antibodies. The trials are ongoing. The data is still being collected. I don't think we have given enough plasma to say either ways whether it works or not. And I would want to reserve any judgments on that, but it's at least safe. And it's just one of these treatment modalities that we're trying out. And I forgot your your assessment of respiratory rate. So that's an interesting question. If you look at the mechanisms of dyspnea and the control of respiratory rate, the brainstem typically does not control respiratory rate with using either oxygen saturation or the partial pressure of oxygen. Respiratory rate is tightly controlled by arterial pH and PCO2. The only exception to that is if the PO2 falls below 55, that's when the medullary brainstem centers start to fire. In this case, I don't think they were tachypnic because of hypoxia, because it takes significant degree of hypoxia to fire those brainstem hypoxic center response. The hypoxia in these cases is probably driven through cytokine release or other metabolic factors. or I'm sorry, the tachypnea in this case is probably driven by cytokine release and inflammatory mediator release rather than the oxygen saturations. Remember, if you take a flight, the cabin pressures are somewhere around 570 millimeters of mercury. And so the oxygen saturation in the ambient air is lower. And if you take a flight and a pulse oximeter with you, you might be 88% or 87% on the flight, but you will not feel dyspneic and you will not be tachypneic. Human beings are quite tolerant to hypoxia. Multiple studies have shown that. And I frequently, when this question comes up, I show people sleep studies, and we see people in the middle of the night desaturate down to 60% oxygen while they snore. Nothing happens to them. They're, of course, they wake up and they have a lot of adverse effects from that long term, but nothing happens to them acutely. So hypoxia is very well tolerated and usually does not trigger these tachypneic responses. So I think it's inflammatory mediators. Did I get all of them? I think I did.
Thank you. Yes, you did. Thank you very much.
All right, thank you.
So, we have a couple of chats in the chat box, but let's push on, and then we'll try to get to that chat box
Sure.
after the next set.
Sure.
Thanks.
So moving on. So ICU triage for severe disease. So my first point is ICU triage is always context sensitive. And what I mean by that is if you're a 900 bed hospital and you have 10 ICU beds, your triage criteria is going to be very different if from a 250 bed hospital with 20 ICU beds. If you're a 250 bed hospital with 20 ICU beds and you're in the middle of a pandemic, your ICU triage criteria is, of course, going to be very different from someone who's not in a pandemic. So that's why it's triage. We have to take into account our resources available. But from institutionally, we had some guidelines that we gave our house staff who were at the front lines of the triage, just to make decision-making really, really straightforward. And essentially, if someone was on 6 liters per minute nasal cannula oxygen or needed 6 liters per minute of nasal cannula oxygen or more, that patient should definitely be in ICU. Respiratory rate is, we use respiratory rate for our fellows, essentially because our general experience is that nobody really counts the respiratory rate. And it's very inaccurate if you look at the charts. So this is a manually counted respiratory rate, and the work of breathing assessment was also done by our fellows. So those two were given some consideration. And then we had, if someone had rapidly increasing oxygen requirements, say they were on 2 liters a day ago and today they're on 4 liters, that person would get some attention. Because that would just mean that we're worried about the disease trajectory. And at the end of the day, the ICU triage would be just clinical gestalt. We did find that a formal policy regarding ICU triage was helpful. It just removes decision fatigue, especially if you're in the middle of the night or if you're very busy. So our hard criteria was 6 liters per minute and respiratory rate of 30 per minute. Just a quick sort of talk about oxygen delivery systems that are available in most hospitals. So when we talk about nasal cannula and we talk about 6 liters per minute, what does that really mean? Remember, the wall oxygen and the oxygen in an oxygen cylinder is 100% oxygen. So that's an FiO2 of 100%. The oxygen in the air we're breathing right now is about 21%. So the oxygen running in the walls is 100%. When you give that oxygen to a patient, what the final FiO2 of that oxygen, it really depends upon how much air is mixing from the room and how much air is coming in from the oxygen cannula. So if someone breathes, normal resting tidal minute ventilation is about 6 liters per minute. If someone's breathing at 6 liters per minute and I give them 6 liters per minute of nasal cannula, their their delivered FiO2 will be different from someone who's breathing very fast. Paradoxically, people who are very tachypnic actually get a lowered final FiO2 because they're mixing in a lot of room air. They may be opening their mouth and they're breathing very hard. So they're breathing less of the pure oxygen that's coming at them. But in general, we have some rules, like an oxygen rate of 6 liters per minute would maybe give you an FiO2 of 40%, provided you're not opening your mouth and you're not breathing faster than usual. And that's when we have, that's why we use a face mask, basically increases the reservoir of the 100% oxygen. This gives you a slightly higher FiO2. Face tent, non-rebreather masks give you a higher FiO2 just because they have a higher reservoir where the 100% oxygen can concentrate. The high flow nasal cannula oxygen is unique in the sense that we can independently control the flow and oxygen. In all of these other devices, the FiO2 that you're giving to the patient depends on the flow, the size of the reservoir, and the respiratory rate of the patient. In the high flow nasal cannula, we make a good seal around the nose, and we can independently control the flow and the FiO2. So when someone's on high flow oxygen, I can give them 6 liters per minute at an FiO2 of 50%. I can give them 60 liters per minute at an FiO2 of 80%. They're separate dials for both. So for acute hypoxemic respiratory failure, high flow nasal cannula is a very good modality. But I presented this slide just to give you an idea of how much FiO2 do different oxygen delivery systems actually deliver to the patient.
Did you routinely, when you put these people, can you back, thanks, quick. Did you routinely put people on a surgical mask over the top of this?
Yes.
Or,
yes.
Okay.
Yes. If they were on high flow, they would have a surgical mask. I think it was
for 2 liters, you'd let them be, but
probably,
4 liters, you'd put on the mask. Okay.
Yeah, 4 to 6 liters, maybe you would put on a mask. 2 liters, we would let them be.
Okay.
But a high flow, definitely, everybody got a mask on high flow. Now, just a little point on oxygen monitoring and respiratory monitoring for these patients. It's important to remember the oxyhemoglobin curve. And the curve is flat out at the end, which means that if you look at this here, you have maybe an oxygen saturation of 93% at point A. Your partial pressure of oxygen is about 75. If you have an oxygen saturation of 90%, your partial pressure is about 62, 63. So while something on the pulse oximetry, when it's above 90, goes down only by 3 or 4%, the partial pressure of oxygen goes down by 17 to 20%. So it's important to sort of note these numbers. And it's also important to remember that most pulse oximeters are calibrated to be accurate up to 90, between 85 to 92%. So pulse oximetry is not a good way of monitoring people who are on higher levels of FiO2. So those who are on a high flow, those who are intubated, we would get arterial blood gases. This oxyhemoglobin dissociation curve can be shifted right or left, and that also introduces some variability. So for us, the preferred method was arterial PO2, especially if they were on non-invasive or high flow or intubated. I think for ward purposes, oxygen saturation works just fine. This is a high flow oxygen system, and as I said, it has a separate air oxygen blender, so you can control the flow and the FiO2 separately. High flow nasal cannula has been shown to have better outcomes in acute hypoxic respiratory failure. This was shown pre-COVID in the Florali trial, which was a multi-center French trial. It's also more comfortable. Practically speaking, I don't know if anyone has tried a CPAP mask. It's quite uncomfortable, and it's difficult to eat, difficult to drink, difficult to talk, and it's hard to keep a CPAP mask on for days and days. But a nasal cannula with high flow is relatively easier. We can get the high flows because the oxygen is humidified and heated, so it avoids the desiccation of the nasal mucosa. High flow also has a mild CPAP effect, and some studies say that they may have a CPAP of about 5 centimeters of water. So there's that benefit, and high flow oxygen is easier to prone. Just from the practical standpoint, there's less interference with the equipment. Non-invasive ventilation, either a CPAP or a BiPAP. For us in the ICU, we basically used the same ventilator for intubated and non-intubated patients. The interface was different, so we had a mask interface. And the reason I put this picture up is that it's important that if you're using a non-invasive ventilator, use a dual prong mask. This means that there's an inspiratory limb and an expiratory limb. Some of the masks have one limb, so it's an inspiratory limb, and the expiratory limb is actually holes in the CPAP mask. That has the highest aerosolization. You want this to be as closed of a circuit as possible, so you need both inspiratory, expiratory limbs, and you need a tight face seal. The risk of aerosolization, I would think, is highest when there are holes in the mask instead of an expiratory limb, and when the face seal is not adequate. So the advantage of non-invasive ventilation is that theoretically it improves the work of breathing by giving extra support, and it may help overcome upper airway obstruction for obese patients. Of course, there is concern for tolerability over the long term. It's very hard to keep the CPAP or BiPAP mask on for days and days. There's always an aspiration risk. It's pumping air into the stomach. So if you eat and your air is being pumped into your stomach, you might aspirate. And then there are reports and studies coming out for ventilator-induced lung injury, even with non-invasive ventilation, because some of these patients have very large tidal volumes because of the pressure support. There's also some concern that they may delay intubation because they mask the deterioration in oxygenation. So those are some pros and cons of non-invasive ventilation. And then a quick word about prone positioning. Prone positioning has actually been studied for almost a decade in critical care. And we have studies starting back from the early 2000s, and most of them were actually negative for any mortality benefit. The first study to be positive was the Prosiva trial in 2013. This was for intubated patients, and this had a significant risk reduction of about 17%, I think, between the treatment control and treatment arms. And then there was a subsequent meta-analysis of all the studies done, which showed there was significant benefit. Some of the points were that the Prosiva trial had actually the highest duration of prone positioning. So more than 12 hours of prone positioning was perhaps the sort of cut point needed to show benefit. And prone positioning is standard of care for intubated patients with ARDS. It's recommended by ATS, SCCM. Awake prone positioning was something that has been definitely studied, promoted, and has been done for COVID-19. And we have multiple case series that describe awake prone positioning. The idea is that it redistributes some of the inflammation, it improves oxygenation, and you can see in the diagram on the right, when the person lies supine, his dorsal lung bears all the weight, all the inflammation, the fluid settles on the dorsal part of the lung. This is also the part of the lung which has the most blood supply, so your VQ ratio will be affected more severely. When you're prone, just because of the shape of the lung, there is less lung tissue involved in the inflammation and the fluid. The weight of the heart is not compressing or is compressing the lung tissue less. And so there are some benefits in the ventilation and perfusion mismatch. And it supposedly homogenizes the alveolar distension. So those are the proposed mechanisms for benefit. And anecdotally, we have seen patients when they're flipped over, their oxygenation improves. And certainly those are the patients who respond to prone positioning. There are some who will not, and there are some who cannot be proned because of various reasons, one of them being weight and body habitus. But it's definitely been studied. And awake prone positioning, I think, has very little downside to it. It's essentially flipping over, essentially tummy time is what I would say to my patients. It's time for tummy time. And a lot of them just took to it, and they would be on their cell phones watching videos in the prone positioning with a pillow below them, and it worked out pretty well for some of them. And you will find case series. There are no randomized trials so far, and we don't know whether awake prone positioning impacts mortality or has not been shown to decrease intubation as far as I know, but it definitely improves oxygenation in some patients, and those benefits may or may not be sustained.
Yeah, Dr. Sukro, there's two things about proning, just really quickly, I knew we needed to move on. One was that I did notice recently there was a new publication that talked about the benefits being quite temporary.
Right.
And as soon as people rolled over, it didn't really make much of a difference, and maybe didn't have a big impact in outcome.
Right.
But the first studies were actually showed significant benefit in COVID-19 treatment. But the other issue I wanted to know was that whether or not you charted this. Did you have proning teams? Because I know some units are having a team of nurses that will roll through on prone rounds to try to encourage proning, or was it just based on your whispering in the patient's ear and asking them to roll over?
So yes, the proning has taken the world by storm, I would say. Our Rush next door actually advertises proning on TV and on the internet as them having proning teams, and it's been for us, we now have a proning team. We did not have a proning team before. We did have a proning protocol. For intubated patients, proning is resource intensive. And especially in a pandemic, in a situation where there is risk of nosocomial transmission, we certainly have to be careful when patients are on multiple vasopressors and things like that. But I think awake proning, we did not have a set. At least for me in the ICU, it was mostly talking to the patient. And just asking them to prone as long as they could, and flip back over for meals. But we now have a proning team and a protocol, and I don't know if there's one on the floor. Maybe Dr. Martin knows more about that than I do. But we don't have a protocol for awake proning in the ICU, if that was your question.
Thank you for that. And if it's possible, and you can round up those protocols that you're using We post
Sure.
these on the PIHOA website along with this
Sure.
talk so that folks
Sure.
can access that kind of
Absolutely.
protocol algorithm-based work. Great stuff. I'm sorry. Please proceed.
Thank you. Thank you. So prone positioning. All right. So let's talk about. Let's move on. Talk about case 3. I have one more case. So this is case 3. This is a 70-year-old man. History of poorly controlled diabetes and hypertension. 2 weeks of fever, sore throat, myalgias, cough and dyspnea. Came to the ED. 82% on room air, but came up to 95%. This man looked ill in the documentation. That was noted that he looked ill. He had bilateral crackles and auscultation, but he was talking full sentences and not using accessory muscles. His COVID screen was positive, and these are some of his labs. This was his X-ray. Again, peripheral predominant disease, confluence of infiltrates, and you see low lung volumes here, not a good lung expansion. The diaphragms are not as clearly outlined in the lung bases, which is concerning. That means that there might be some consolidative process in the bilateral lower lobes. He was admitted to the general floor, treated with hydroxychloroquine and remdesivir. Eventually his oxygen support was escalated to 6 liters per minute. He developed some pleuritic chest pain. He had worsened dyspnea and tachypnea. He was moved to the ICU, started on a non-rebreather. Awake prone positioning for this man was not poorly tolerated. And because of his new chest pain, a CT angiogram was done. And this is one cut from a CT angiogram. And I put this up because it's really remarkable. If you see this line, this demarcation, this is called subpleural sparing. And this is a typical feature of interstitial lung disease. And if someone had shown me the CT scan, pre-COVID, I would have said it's subpleural sparing and alveolar ground glass infiltrates bilaterally, suggestive of NSIB, non-specific interstitial pneumonitis. But we know that this man had COVID, and the CT angiogram did not show a PE. So he had bilateral ground glass opacities with subpleural sparing. And you don't see dilated veins, so this goes against fluid overload. Fluid overload would have similar ground glass, but you would see dilated veins all the way to the peripheries, but we don't have that here. So this is alveolar and interstitial inflammation. Now this is a plot of his respiratory rates, oxygen saturation, and heart rate. And as you can see, this man was also, at the top is the heart rate, middle is respiratory rate, below is oxygen saturation. I don't know if you can see the numbers, but this red line here is 100 beats per minute for his heart rate. And if you notice, this man's heart rate was higher than 100. And in fact, went up to 130, 120. And his respiratory rate was high, but not as high as the other ones. His respiratory rate is between 25 to 40. This red line is when he gets intubated. So everything just sort of flattens out because now the machine is breathing for him, and his heart rate goes down. This red line is intubation line. But what I wanted to point out here is that, yes, this man is tachypnic. Yes, he's hypoxic. But the difference here is that his heart rate was high. And that just, to me, that reflects a decompensated disease. And if you notice, the decision for intubation here was probably made on this data point when his heart rate was 150. That's when people decided, all right, it's time for something more, because this man is clearly getting sicker and sicker. But you can sort of appreciate a trend of worsening respiratory rates as well. Just a few hours before his intubation. And of course, he's profoundly hypoxic. So he's intubated on day 5. He's placed on the ventilator. We use low tidal volume with permissive hypercapnia. He is very severely hypoxic, even on 100% FiO2. He's deeply sedated. Paralytics are started. PEEP titration is done by driving pressure. And I'll come to this in a little bit. His plateau pressures are less than 28, which means his lung is not very stiff. And his actually measured lung compliance is almost normal, which is sort of unusual for someone who is so hypoxic with ARDS. But an hour after intubation, the patient starts to desaturate. He has worsened hemodynamics. His peak pressure alarms are sounding, and we do a lung ultrasound, which suggests a pneumothorax. So this is his X-ray. And you can see the deep sulcus sign. Deep sulcus sign in an intubated patient, sometimes the air doesn't track upwards and goes in the sulcus here. So deep sulcus sign. You do see a lung outline here, so you do see air at the top as well in this case. So he has a moderate pneumothorax. And as you can see, his infiltrates look like they have progressed. This is post-intubation X-ray. ET tube is here. So he gets a pneumothorax, a chest tube is placed. He develops severe RV failure, refractory shock, multi-organ dysfunction, renal failure, bacterial superinfection, stress ulcer bleeding. He's treated with everything, full support with the ventilator, paralytics, nitric oxide, chest tubes, vasopressors, CVVH, anticoagulation, remdesivir, tocilizumab, hydroxychloroquine, steroids, and he's treated for a month and he eventually passes away. This is case 4, 63-year-old lady with history of diabetes and obesity. Similar story, multiple family members with COVID-19. She has a husband hospitalized with severe disease. She's febrile and she's tachypnic. She's taken to the ICU for severe hypoxia. She's intubated. And her story, I'll cut the long story short, and I'll give her story in just pictures. And so this is her initial X-ray. You can see similar bilateral interstitial infiltrates. This is her X-ray a few days later in the ICU. You can see all of that plastic and support devices and a worsened infiltrates bilaterally. And you know, this is one of the most remarkable X-rays I've ever seen. You almost see no aerated lung in this. Severe bilateral consolidative and interstitial infiltrates. The only area of aeration is probably at the apices of the lung. At this point, you can see that she's undergone a tracheostomy. And this is her X-ray a few weeks later. Some improvement, maybe in the aeration. You can also see 2 chest tubes on the left side. This is because she developed a pneumothorax. So we have 2 pigtail catheters on the left lung. And this is her X-ray just a few days ago. And you can see that most of the right lung is aerated. The chest tubes are out. The left lung is aerated too. This patient she's still in the hospital. She's been in the hospital for about 2.5 months. And she survived severe COVID illness. I don't want to give her whole hospital course. It would just be a lot. But suffice to say that she went through a lot of complications. She had a very difficult illness, but she survived. And she survived with good organ function. She's awake, alert, communicative, with normal renal function. And she's actually not on the ventilator anymore. She's breathing through a trach collar. So this is one of those patients who made it so far. She's still in the hospital. She's not been discharged home. and she continues her recovery in the hospital as we speak. So my topics of discussion for these two cases would be intubation, ventilator management, prone positioning. I won't. I sort of already discussed it, and then general critical care. So I think one of the most important decisions in critical care is the decision to intubate, and the decision to intubate is usually a composite assessment of multiple things and is never really a consequence of predetermined indices. If you read any clinical trial in critical care medicine, they usually have an intubation criteria where they'll say respiratory rate of 35. We intubated patients if they met the following criteria: 1, 2, 3, and 4, and the criteria would be respiratory rate of more than 35 or oxygen saturation of X and a PO2 of Y. But in real life, it's always a composite assessment of vital signs, clinical assessment, patient views and preferences, and resources available. And one of my ICU mentors, Dr. Samuel, would always say, if you're considering intubation and the patient cannot talk you out of it, then intubate them. For COVID-19, there's been a lot of debate on early intubation versus late intubation. And that debate is still ongoing. And there's some assumptions behind intubation. And one of the assumptions is that intubation changes the trajectory of the disease. And the way to look at it is there is an idealized benefit of invasive mechanical ventilation, but that benefit probably decreases with increasing age, comorbidities, and frailties. So it's again an assessment of the patient and a clinical decision whether a patient would benefit from intubation or would not, and it's hard. Of course, sometimes patients have DNR orders and things of that sort. So those are situations which have to be dealt on a case-to-case basis. But there is some debate. Early intubation, the proponents of early intubation say that it lowers mortality and it avoids something called PSILI, which is patient self-induced lung injury. And the underlying philosophy is do something now before it's too late. Late intubation follows the strategy of if it ain't broke, don't fix it. And this concept of permissive hypoxia, which says why intubate the patient who is, otherwise looking okay. Yes, they're tachypnic. Yes, they're hypoxic, but they're talking, they're texting on their cell phone, and some of these patients, you tell them we're very worried about you and we want to put you on the ventilator, and they'll actually tell you why. I'm feeling fine. So again, the proponents of this technique would say that it lowers overall ICU mortality. It avoids the risks of invasive life support systems, the tubes, the lines, the infections, and it remains to be seen whether one strategy is better than the other. And of course, when I use the words early and late, I'm assuming that there is one perfect time for intubation. Whether that exists or not is debatable. But it's interesting. It's an interesting question because if you look at studies from different countries, you'll see different patterns emerge, and this sort of gives a sample of that. So, for example, in New York, out of these 5,000 patients that were hospitalized, 1,200 went to the ICU, and almost 90% of them were intubated. Whereas in Italy or in the UK, for example, out of the 3,000 or 4,000 patients that went to the ICU, only 59% were intubated. Now Of course, there's the issue of, what was their ICU criteria? What were their intubation criteria? Was there rationing of care? Did they use more non-invasive support? Did they use more high flow? Those are all questions, but there are differences in practice patterns. So when people talk about the need for intubation, it's really the clinicians need to intubate that they may be talking about, because a lot of these cases would be managed differently in a different ICU. And that has an impact on interpreting mortality data. So, for example, for patients who were mechanically ventilated in the ICU, in New York, they report that 282 of these people died. Only 38 survived ICU discharge out of 1,151. And some of them are still receiving care. And so their range of possible mortality is 24.5 to 96.1. And in the UK, it's 698 people out of 2,000 who died. Only 355 have survived a hospital discharge with a similar sort of mortality range. So I think some of these figures will change as time goes on. But really for me, the outcome that I look at is survival to hospital discharge. And I would want to know how many survived with good independent recovery. If someone's trached and on multiple support devices, is that, and they die 6 months down the line from complications, would that be considered survival? Would that be considered as a good outcome? Is really debatable. And so when people talk about what is the mortality of patients who were intubated, it has to be put into the right context. And this has been sort of touched upon, and there's a lot of debate on early versus late intubation, and the concept of the silent happy hypoxic. And some are moving away from early intubation and sort of following a late quote unquote intubation strategy. And there are various considerations for that we just talked about. A quick touch on intubation itself. Once you've decided to intubate, how to go about this. We had intubation protocols where anesthesia service and anesthesia attending actually did all of the intubations once the protocol was in place. In the early stages of the pandemic, we did our own intubations, and this is what the PPE that I used. This is a PAPR with an N95 mask and goggles on. So I use this for intubations and bronchoscopies. And of course, I would have a full gown covering that with masks, with gloves and shoe covers. And we sort of used rapid sequence intubation with full paralytic for every single intubation. The airway societies have given some guidelines for intubation, and they have sort of given some practical points about where everything should be. You obviously don't want to be running in and out of the room for equipment. If you have a difficult airway, you want to make sure you have all the tools available in the room. They also recommend that video laryngoscopy should be used for every intubation. And that's so you avoid being in the direct line of sight of the larynx, so that the patient doesn't cough into your face. But the dictum is safe, accurate, and swift intubation. You certainly don't want trainees to be intubating these patients as far as possible. You don't want failed airways. You don't want to bag them. All of these things increase aerosol generation. So in summary, strategies for mechanical ventilation. We have very good data that low tidal volumes is good in ARDS. you should use, and these are simple strategies for routine ARDS management: low tidal volume, permissive hypercapnia, lowest level of sedation, paralytics if needed for synchrony. Remember that if a patient is dysynchronous with the ventilator, he escapes the effect of low tidal volume. If he's double triggering, he's taking more tidal volume than you want him to. Those patients should be sedated or paralyzed if needed. By individualized PEEP, I mean that we should not use very high PEEP for those who don't have stiff lungs. And so the ARDS tables give FiO2 values for PEEP. So for example, the ARDS table would say that if you're an FiO2 of say 80%, then if you follow the high PEEP table, you should have a PEEP of 18. What I suggest is that the PEEP should be titrated to that patient's lung stiffness rather than his oxygen requirement. And I'll come to that just in a few moments. And we monitor oxygen saturation and arterial gases. And we certainly tolerate hypoxia if there's no organ dysfunction. So a quick point about lung stiffness. This is a study from Gattioni in Italy. And they described two phenotypes of COVID-19 ARDS, one with high lung stiffness and the other one with low lung stiffness. And lungs, if you imagine a balloon with water, and if you want to blow up that balloon, it will be hard. And that would be a stiff balloon to blow up. And that's essentially what it is in ARDS. If you have a lung full of inflammatory fluid and inflammation and scarring and fibrosis, that lung would be harder to expand. The ventilator would have to work harder to blow air into that lung, and that will be considered a stiff lung. In COVID-19, we have seen that some cases, they look bad and they look like they would be stiff on imaging and certainly by their degree of hypoxia, but they actually expand pretty well. Lung is recruited pretty well with low amounts of positive airway pressure. And that is what we would call a type L phenotype of COVID-19. As you can see the CT at the bottom, it looks pretty severe with bilateral infiltrates, almost a consolidative process in the lower lobes. And after just 5 centimeters of positive airway pressure, you can see how much lung has been recruited and the FiO2 has improved. This patient certainly doesn't need 18 of PEEP. If you can recruit lung, recruit it with the lowest amount of PEEP possible. High levels of PEEP have their own deleterious consequences. So it's important to measure lung compliance and plateau pressures and individualize the level of PEEP required. I talked about prone positioning a little bit earlier. For intubated patients, I think one has to sort of develop their own institutional criteria regarding the BMI or whether or not patients on CVVH, whether they're vasopressors, how many vasopressors, if patients with pneumothorax should be prone, and things like that. This is sort of a summary slide from Maimonides Medical Center on what they did for managing these patients. So you can see that most patients who were in the ICU, they were trialed on high flow nasal cannula, non-invasive measures. And once they were intubated, they used lower PEEPs here, like PEEP 5 to 10. And they were a little bit more liberal on tidal volumes. But some of the general strategies of managing ARDS may have to be modified for COVID-19. So in summary, closed respiratory monitoring, low tidal volumes, individualized PEEP, and prone positioning are recommended for COVID-19 ARDS. Now my last section on the preparation for a COVID surge, especially for the ICU, I think it's good to have triage policies for hospital admission and ICU admission. I think one thing that is very, very important is policies for family communication and designation of surrogate decision makers. From personal experience, I can tell you that dealing with families is very, very difficult because they're not allowed to come. They're not allowed to visit their loved ones in the ICU. And from a family's perspective, the last they saw of this patient was when they dropped him off in the ED. And then the next thing they hear is they're transferred to the ICU, or they're going to be placed on the ventilator and they're deteriorating, and they're not able to visit. So that is a stressful situation for both the family and the staff. It's good to have code status discussions early on. We certainly made it a policy that every ICU admission would have a surrogate decision maker assigned and a code status established when they hit the ICU. Like you have intubation checklist, you should have an extubation checklist to minimize nosocomial transmission. We had institutional policies on limitations of care and futility, unilateral DNRs, and we certainly had our ethics team consult on difficult cases. We had policies on code blue and cardiac arrests, how to respond to them or how not to respond to them. And essentially, we emphasized that all healthcare workers should wear PPE before going into the room for even cardiac arrest or code blue. Also, it's a good idea to have engineering administrative changes, such as having a closed and designated COVID unit. We modified our rounds. We would round with pre-round on computers first. We would minimize entry and exit into rooms. We would share tasks between the nurse and the RT and the physician. We did not do hourly AccuChecks and insulin drips just to minimize nurse exposure. We placed the ventilators closer to the door, and we actually placed the IV pumps outside the doors so that drip rates could be changed by the nurses without going into the room. PPE was managed, and you know, there are other things like rotation schedules to avoid fatigue and ensure that there's enough staffing in case people fall sick. And then, you know, there are other miscellaneous things like transportation policies, endoscopy, more capacity, and patient belongings that I think every institution has to think about. So that sort of concludes my talk. And I have pictures of the PPE that I used while rounding in the ICU. So it was a surgical mask, N95, face shield, hat, and then I would wear a patient gown, which would be changed between rooms. And the second picture is essentially family isolation. Both me and my wife are doctors, and this was our new normal. FaceTiming each other in separate rooms sometimes, taking turns taking care of our baby. That concludes my talk. If there are any questions, I would be happy to take them this time.
Wow, both our speakers have just been spectacular. I know I'm speaking for all the listeners when we thank you for the time that you put in and the care you put in to collate this difficult topic and to translate it and make it sort of grounded and practical. Everything we kind of asked for last month when we first started talking. So heartfelt appreciation to you and your team. We did have a couple questions that we might want to take a few moments of. We're well over time, of course, and still recording. So folks that have to drop off, they can pick up the recording posted on the PIHOA website, which I have added to the chat box. So one of the questions, interesting question from Hannes, was that how critical was it for video-assisted intubation? It's we're able to procure some devices for the islands and ship them as needed. Obviously, these are expensive. I just looked and I saw they price, you know, $5,000 to $15,000 for a video a laryngoscope in a unit. We don't have lots of experience, some less than others, for intubation. How important was that?
I would say that one should use the tools that they're comfortable with. If you know, a hospital does not have video intubation, you know, there's slightly different techniques, and there is a learning curve to video intubations. It's different from direct intubations, and sometimes it can be even harder. The reason airway societies have given that recommendation for video intubation is that it keeps you away from the patient's mouth. You don't have to look into the mouth. You can look at the screen, and so theoretically, it decreases your risk of transmission. And again, this is theoretical. Now, if you use video intubation and you're not comfortable with it, and it causes more problems, and then it makes the intubation more difficult, I would say that probably has a higher chance of a bad outcome for both you and the patient, especially if you have to bag the patient or you do things in a rush. So I would say one should use the technique that they're most comfortable in. The most important thing is that the patient be intubated swiftly and accurately. And if you were very good with DLs and direct laryngoscopy, I would say go ahead with that.
Another question that came up sort of is about apportioning ventilators. So did you ever run out of vents? Did your ICU ever reach its capacity?
We did not run out of vents. Our ICUs did reach capacity. Our medical ICUs, we have 2 medical ICUs that were full. We were boarding in surgical ICU, in cardiac ICU, in neuro ICU. We did not run out of vents. We had adequate ventilators. But yes, policies were in play for ventilator in case we would run out of ventilators.
Mm-hmm.
And we did have unilateral DNR policies. We did have futility policies, and I think those are good to have in case you know, things become that bad. For us, we did not run out of ventilators, no. So we didn't have to ration ventilators at all.
Well, if you wanted to take, you know, your administrative letterhead off of those criteria, I'm sure that people aren't really excited about sharing that kind of thing.
Yes.
But, we're going to reach capacity more quickly in the Pacific than you folks do. We can't share ventilators from one hospital to another, right, because it's usually just one hospital. We do have a good number of ventilators. We're able to go from very few in the region to at least enough to cover for every 2,000 or so patients. There's at least one ventilator, which is quite an increase from before. And they're the LTV 1200s, which I see were in one of your pictures, your CPAP picture, I think.
Right.
They were the ones you folks were using. So if you had some sort of hints or some guidance about when you were approaching your max ventilation number, how you would begin to think about apportioning that, I think, as sensitive as that topic is, I think it would be helpful to us as well. And
right.
There are some questions there.
So I think what we had was, I think the one thing that is important is conversations. I think before just, you know, talking to the patient and their families and sort of giving them a picture. I mean, we know that people who are older, who have multiple comorbidities, have a very high mortality rate. And even if they survive the critical illness, the quality of life, ventilator dependence, and dependence on you know, nursing home care or other institutionalized care is higher. So we did have conversations with patients and their families about this. A lot of the families and a lot of the patients actually did not want to be placed on ventilators, especially those who were older. They, you know, everybody's watching the news and they knew about this, you know, as much as we did, and they did read all about this in the news. And so some families did opt for DNR. Some patients did opt for DNR, but in those who didn't, we did not run out of ventilators, so we did not have to institute those policies, but we did have policies based on the age and the number of comorbidities for ventilated patients. And again, some of this would be clinical decision-making and triage, and it was left to the clinician. And we had ethics consult available to us for handling those difficult cases. What I would certainly recommend is having a DNR policy for those who have exhausted maximal ventilatory and cardiovascular support. So we did have for someone who's on you know, maximal ventilatory support or you know, 3 or 4 vasopressors and severe critical illness, who was not responding to treatments, we would not do CPR for these patients if they arrested. One, because they were already on maximal vasopressors, and CPR is generally not helpful for respiratory failure. It would be futile, and we did discuss these with these things with the families, and these are all difficult conversations to have, and these are difficult topics to make policies on, but I think they should be made. And I think at the end of the day, every institution has to get together and come up with their own policies, because I mean, you know your patient population better, your resources better, and what would be a good policy for us might not be a good policy for you, or for some other hospital. So I really think.
And right now, as Dr. Martin mentioned, you know, I think that most of the islands get straight A's because they've just prevented any cases from arriving, which is the best way to manage these cases, is to not have them. So I think that has to be recognized, and we appreciate your insights into the prioritization of patients, and look forward to possibly getting even a list based on comorbidities or age or however.
I don't want to say that we have an age cutoff, because again, we've seen 85-year-olds with prostate cancer, survive this illness, and 35-year-old with no past medical problems die with respiratory failure.
Right.
So it is a very individualized decision, and I think I would just say strong family discussions are the most important thing from day one.
Well, you and Dr. Martin are going to have to fight over who's the meat and who are the potatoes, but this has been a phenomenal section for us. We really appreciate it. It's what we were hoping for. And I cannot tell you the comments that I'm hearing from the other islands. I think one of them that came in the other day was, as we posted these, thank you. These are gold. This is gold to us. So we appreciate the wisdom and the PowerPoints to share. We know things will change. Next week, we're going to have another session, and this will be Patricia Macias, Dr. Macias, who is maybe the instigator for getting the rest of Cook County committed to helping us in the region. we'll be talking about releasing patients from care, and we're hoping that might even include a criteria by which you extubate people, because there was a question about extubation criteria, which I think we'll leave to her next week. And then Megan Devine, an intensivist from Texas, will give us another perspective on treatment of COVID disease following that. And then we'll move into some specialized topics, including the following week, the 23rd of July, 24th for you folks in the region, about COVID and pregnancy, management of deceased cases. And then it's going to be time to circle back around and talk again about labs, new labs, vaccine. We haven't had a vaccine lecture, and that's going to be critical. We'll have another update of medications and a review of the regional EPI. And then depending on demand and what we perceive as the need during the one-on-ones, when we're talking with your epidemiology teams and with your preparedness teams and with your medical administration and your ministries of health, please continue to provide them with feedback for what you want to hear about, or email me directly, hld4@cdc.gov, and we'll continue to expand as we can. We surely appreciate all of your time. We're well over time, but certainly every minute of it is quite worth it. And thanks again to our speakers, and we'll look forward to seeing everybody next week.
Thank you very much. Thank you.
Thanks a lot.
Thank you a lot.
Thank you.
Thank you.
I was supposed to ask